My name is Miranda Klassen. I am very privileged to be here with you. I experienced an AFE during the birth of my son in 2008. And to orient you back to 2008, there was no TikTok, there was no Instagram. We were still asking Jeeves for advice, typically like, what good restaurants? And like my newborn kiddo, Google was in its infancy as well. So I just want to reorient us back to that time. And so in the moment that my son was born, I didn't realize that so too was going to be a new passion and a new path forward for my career. 4 months after this picture was taken, which was taken 2 days after he was born, he was asleep in the NICU. They brought him out to me. You can tell that I was still hooked up to a lot of lines. And I really didn't have a lot of understanding of what had happened to me, let alone even sort of realizing that I was a mother. And he was asleep, and I sort of grovelly said, "Hey, Bubba." And he immediately woke and started to cry. He's been pretty, he still likes to cry. Or make me cry, because he's 17 now. But what I realized too was that instant, like, I became a mother. But 4 months, 4 very quick months after that, I faced my 32nd birthday. And for me, my birthday is a difficult time. It's not one that I really enjoy celebrating anymore. Really, his birthday is like the big day in our family. But I knew that I didn't want anything material, but I really needed some time alone, and I really wanted to better understand what had happened. And guess what? Jeeves did not know anything about amniotic fluid embolism. So I had to go to the library, a place that I had found a lot of solace during college. And so I went back to the library and started to look and started to read. And as I read, I realized that the articles were very complex. I didn't understand half or more than half of what I was reading. Again, remember, Google wasn't around, nor was ChatGPT, so I really had to figure out what DIC was. And as I read, one of the things that what I did understand was that it underscored exactly what the providers had told me when I woke up or when I was extubated, that this was extremely fatal and most women passed away. At the time, AFE was roughly 80% fatal. Again, this was before a lot of ECMO usage. This was before hospitalists. This was before TXA and bundles. And so the fatality rate was incredibly high for mom and for baby. And while I was there in the library, as fate would be, blogs were a big thing back then. And I came across a blog, and this blog caught me by surprise. It also caught the librarian by surprise, because she was actually sitting with me as I was trying to look for articles. And essentially, it was a sister talking about the loss of her sister and her nephew, Jenny and Broden. They had passed away. When I saw the date, I gasped. It was April 1st of 2008. My AFE was April 9th, 2008. She too was blonde and blue and was having a little boy. And so the seed of survivor guilt that started at extubation started to flourish in the library. And I thought, what a cruel, cruel day of April Fools, because this was certainly no joke that mothers and babies were dying in the 21st century in the United States. And so I knew I needed to do something. And so there in the library, I had formed in my mind an organization that would support research, and it would support families who had gone through it. As I read the articles, I found a common name that was on all the articles. He was either quoted or it was an article by him, Stephen Clark. And God bless these printed articles, because you first authors know this, your email or your phone number is on there. Now again, 2008, remember, we protected our emails. This was like your social security number. So to have an email address of somebody was pretty exciting. So I decided I would send Dr. Clark an email that I just had an AFE, or so they thought, and I was going to start this organization, and I didn't want to do it without expertise. He was the foremost expert in Swan scan catheters. He was the foremost expert in AFE, and really founded critical care obstetrics. And so I had a trip to the library, and then A month later, with a massive pulmonary embolism in my IVC filter that I did not know about, hopped on a flight to Utah. If you're not from Utah, there's definitely elevation there. I did not feel well, but I was not going to miss this meeting. So I met with Dr. Clark. That was 17 years ago. He professed his support along with his colleagues, and he is still a mentor, a friend, and very involved in our organization and our research. But enough about my story, because why I'm here is really talking about centering the patient, and I have some patient stories and some provider stories to share with you. This is a special one. Told myself I wasn't going to cry. This is Teresa, and this is her husband, Dave, and this is Dave kissing Teresa, welcoming like the new year. And it's one of my favorite pictures of them just because it encaptures a lot of their personalities. I didn't get to know Teresa. Unfortunately, Teresa passed away, but I did get to know Dave very well. He was actually the first family that came to us 6 months after I started the foundation. In fact, this weekend, I'll actually be cheering Teresa's sister on. She's going to run a marathon like her sister did, and so I'll be cheering her sister on, Anne. But I've become very close with their family over the last 17 years. Everything from her parents, her best friends, her dog, you name it. I was somehow welcomed into this family and into this space because I was so passionate about ending it and making sure that women like her weren't lost. But I'm actually not here to talk about Teresa. I could literally spend our entire conference talking about her. But I want to talk about her anesthesiologist. Dr. G was the attending the night that Teresa earned her angel wings. He had just turned 40. He was in a small town, and I remember telling Dave on my many calls to work, the way I would talk to Dave every day, and I told him how important it was that he needed to, take care of himself, and so he was going to the gym, and he happened to see, I remember the day he called, and he said, I saw Teresa's anesthesiologist at the gym. And I was like, well, did you guys talk? And he goes, no, we kind of like had an unspoken bro code, like we knew who each other were, but we weren't gonna talk. And he saw him a couple of times over the next year. What we didn't realize was a year later, a year and 2 weeks later, Dr. G would earn his angel wings too and took his life. And I have no idea what events transpired that led to that outcome, but I did find something that was quite interesting, and I want to bring this to your attention. Is on his obituary page, there are countless tributes to him and what a special person he was, but one of the tributes was incredibly telling. It was a nurse who had been in the same room with him and Teresa that night, and what she essentially was saying was, we understand that your pain was heavy. We understand that you didn't want to come to our unit ever again. And we missed you then, and now we're going to miss you going forward. So today, I want to talk about how our organization has learned that we have to not only support patients and their families, but we have to support all of you too. And so our job is to try and keep you, one, at the bedside, but to be ready for these events. So in short, this is sort of what we do. We are grateful for people like you, for May, for Elliot, for Viba, for Paloma, for Barbara, for David, for all of our colleagues and many that I just named as anesthesiologists that trust us and are willing to lean into us and collaborate with us and give us the validation that we need and the input that we need to not only do our research, but to do all of the other things that create resources for you. So we essentially help provide you or prepare you for the event. We help support you during the event, and we are definitely there in the aftermath of the event. So I want to talk mostly about, what inspired me that day was the research. My background was biology and chemistry. I thought I was going to study bugs. Now I'm studying moms. I'm actually studying, I think, what might be the hardest thing in the world to study, because we know virtually nothing about it in the last 100 years. But what we decided was to revamp Dr. Clark's registry that ceased in the 80s and reinitiate that registry. And then we also came to realize that retrospective data could only get us so far, that it really comes down to getting specimens. We really need to study what is happening, what biomarkers are involved, the proteomics, the metabolomics, you name it, we want to know what is going on. And there's no way that we can do that without specimens. Our registry is the largest database in the world of cases. I've been privileged to serve on the MMRC in California. Thank you, Dr. Main. And so I've read all the cases from our registry and many cases as well. And again, I can just underscore that what we really need is specimens. But we can't do better for patients if we don't get these specimens, and we can't get specimens if you don't know how to give us specimens. So that's why opportunities like this and collaborating with patient organizations is so valuable. In addition to our research, we offer a number of resources. This is a very busy slide, but what I want to draw your attention to first is on the bottom left is our simulation toolkit. I know some of you have mentioned SIM. I believe there's going to be a SIM presentation later in the afternoon. Wow. Tell you what, talk about triggers. Being, I think straight out of the gate, I think the next year, my husband, which I probably should have shared, is an ICU nurse. He became an ICU nurse after our experience. We thought it would be a good idea to present at a hospitalist conference, and they decided they wanted to run our SIM, or run our case. And so I played the voice of the patient, my husband played the voice of the husband, and we did a simulation of our case. And it was fascinating to me to watch simulation sort of unfold. So I've had like this very deep respect and admiration for the process of SIM. I've learned a lot over the last 17 years. But the SIM toolkit was many, many years in the making. It was a collaboration with Clinical Concepts in Obstetrics and Julie Arafay, who is a simulation expert and human factors expert at Stanford. So we developed this turnkey toolkit for essentially low fidelity to high fidelity. It has everything that you need in this kit, and it was really designed to assist units in running AFE SIMs. And some of the information we got, we just actually presented at A1, and it was really fascinating to see. We had almost 600 people in the room. They had to turn people away. It was standing room only, and it was because these nurses were very hungry for the information. And what we asked when we were talking about, so this presentation was on the implementation of simulation, and what we asked was, do you ask your anesthesia colleagues, what do they need to be successful when they come rushing into the room? What do nurses need to be successful, but what does the ad hoc team need to be successful? And so we asked a series of questions. What you need to ask your anesthesiologist or your CRNA, what do you need to be successful in every labor room if this happens? So afterwards, we opened it up for questions, and some of the questions that we heard was, how do we get our colleagues, our clinician colleagues to the table? And what I heard them say was, we need our colleagues, we need anesthesia to come to these things, because when they come to our SIMs, we communicate and we figure things out. We realize that, oh my gosh, somebody doesn't have a key to labor and delivery. A little side note, I told my husband after learning that fact, he leads the code team at our hospital where I was, and I said, hey, just see if you can get in to labor and delivery. He's like, oh yeah, I can get in anywhere. I was like, okay, we'll try. Well, he couldn't. It was an IT risk management issue. So it's really interesting the things that come up with simulation, and it was really interesting to hear the dynamic of nurses talking about how profoundly and desperately they wanted anesthesia colleagues to be there. I'm so sorry, can you scroll just a little bit down for me? I don't know how I can, thank you, maybe that's me, I'm not sure who's doing this. In addition to our SIM toolkit, we also have a number of other resources. We have a checklist that helps labor and delivery nurses prepare not only the patient, but prepare the room so that when you guys come rushing in, you have space at the head wall, you have the ambu bag set up, you have the tools that you need necessary to intubate this patient. We have fact sheets, we have patient lay-friendly crisis handouts, we have a course. We have tried to make every barrier be removed, because the barrier of AFE is that it's infrequent, but it's very fatal. But you guys have a lot of cognitive load. You guys have to know a lot of things about a lot of things, and thank goodness I only have to know one thing, which is AFE. It just happens to be very challenging. We've created badge buddies to assist nurses as well, but we also have a hotline, and this has been modeled after the malignant hypothermia hotline. How many of you are familiar with MHouse's hotline? Okay. How many of you were aware that AFE had a hotline? Oh my goodness, you get a prize. You get a prize afterwards. It might just end up being a hug, but you're definitely going to get a prize. And so that's why I'm here. I want to share this hotline with you. So while I'm not a provider, our hotline does exist, and we are looking for a little begging. We are looking for providers to assist us. But this hotline allows for you to call either during an event or after an event, so we can walk you through next steps, because as I've come to learn, a lot of people don't know what to do when these events happen. That is where this little card that maybe you have on your table or maybe you don't, I could only bring so many because those pesky airline poundage. But essentially when a loss occurs, your autonomic nervous system, especially for nursing colleagues who are not as stress inoculated as maybe some of you, are having a pretty significant response. Dr. Vogel, I think you were hitting on some of this as well. But what we try and do is we try and normalize a very, very, very abnormal situation and step in to assist, recognizing we've been there, we understand where risk management's coming from, we understand where different providers may have different feelings, and no case is ever the same. We start to learn about the family dynamics. We start to learn about the unit. Does the unit have a lot of support? Do you not need a lot of support? When you call our hotline, you activate essentially all of our resources. We send food. We send food at 2 in the morning. Thank goodness for DoorDash. We work on how to prepare your conversation with the medical examiner. I've done an extensive amount of work in maternal autopsy, which is a discussion for another day or tonight, if you're up for that. But we advocate for autopsy. We discuss the importance of it. We help the family preserve immediate memories, because unfortunately this patient may pass away and may need to go to the morgue. And so we are working with the families immediately on what they need to do. And all of this support that we've done has also been under the guise of expert perinatal trauma experts in our community that have either lived this experience themselves or been touched by it. We do a number of things for our families. You could probably tell how emotional I was with Teresa. Every story is important. Everyone is meaningful. I have a wall of their pictures a wall of their black and white photos in my office, because I do this work for those that we lose, but we also do this work for my sisters, if you will, those who've survived these events. And there's a lot of platitudes. I think someone also shared this, maybe it was probably Dr. Vogel, that shared the platitudes of well, you're just so grateful to be alive and it's a miracle and things like that. And so we have to really help these patients unpack that you can be grateful to be alive, but you can also be really sad and really angry and really frustrated or confused or traumatized. So we've created a number of resources. We have a very comprehensive survivor guide. And you may be thinking out here, but we don't necessarily get to see this patient. And I'm going to share some other stories. But this survivor guide is comprehensive. It's interactive. It can be airdropped to the patient's family, to the patient themselves. It can be downloaded. We will send them a hard copy as well. We also created a survivor clinical summary form, because guess what? You guys have done a good job keeping us sedated, and we have no idea what's happened to our bodies. And so that autonomy and not understanding what's happened, we've created a form that can be completed by the clinical team, all of you that are supporting this patient, to sort of summarize what happened to our bodies and the key findings and the key interventions, so that when we go out and we go to the next doctor's office visit, which we have a lot of ologists we have to see after these events, contrary to what many people think, that the event is over It is not. Many of us have long-term physical and mental health sequelae. And so we've created this two-sided form to assist in the continuity of care for these complex patients. But we really have created a warm sisterhood, and we support not only survivors, we support grieving families, widowers, spouses, siblings, best friends, you name it, we have a group for it. But I want to share a story, which is an interesting story, and again, it involves an anesthesiologist or CRNA, about resilience and about community and about education and why our organization has been able to support more than 200 women AFE survivors go on and have a subsequent delivery. And fortunately, knock on wood, none of them have had a subsequent event. On the left, in this whole picture, Olivia to the left. Let me just tell you briefly about Olivia and John, her husband, both in the military, both lieutenant commander for John. He's an MH-60 pilot. She's an ED trauma nurse. They've been deployed. They've seen their fair share of not so good stuff. Let me also tell you, she's a wicked redhead from Brooklyn who played college hockey. So she is very, very tough mentally, physically, and she's become a dear friend. But in this left is shortly after she was taken off of ECMO and getting to see her son for the first time. But what happened during her AFE was a little unusual, but also bears to be repeated, is that she did not immediately lose consciousness. And so during her AFE, as she was becoming hypoxic and hypotensive, there was a flurry of stuff. Now, mind you, she's an ED trauma nurse, so she knows what's going on. Unlike people like me who are like, am I gonna die? That's what we say. She's out here calling the shots, and she calls herself like an old sweary broad. She will tell you that she was literally calling her own code, like halfway through it, telling people what they needed to do. So her sweet CRNA, Kim, happened to be there, and Kim was not only caring for Olivia, who had probably some sweary words, she also was trying to manage the code, and then additional colleagues come in with different military ranks, and there was a heated discussion about intubation and when intubation should be done. Long story short, Olivia was intubated. She developed ARDS and did go on to require ECMO. She was transferred to another facility off base, and there at the next facility, she was sedated, but what was unknown at the time was that, remember, she's a redhead, she is a hyper, what do you guys call it? Metabolizer. Thanks, see, I read your lips. Can you tell I'm not a provider? So she's a hypermetabolizer, so she ends up not actually being sedated, but she's paralyzed. So what does she see? Ceiling tiles. These look nothing like what she was looking at, the old kind with like drips and stains, right? She also hears, how many of you know anything from MTV, Ridiculousness? That's a little pop culture reference, I'm sorry. Anyways, it's a silly show, and there is someone on there who has a horrible laugh, and that is all she heard. It was on repeat on MTV on the TV, was staring at ceiling tiles and hearing this laughter. She did a lot of work. After coming home, her husband, John, ended up being deployed. Guess who he was deployed with? Kim, their CRNA. So they meet on the ship. They talk about their shared perspectives. Kim shares how difficult that day was for her, how she's been wanting to know more. So off she goes on the ship. Her and John become fast friends. She earns the title of Auntie Kim. And now we come back, John comes back from deployment, and guess what Olivia's been doing? She's been emailing me, and she's been asking me 1,000 times, what's the data for subsequent deliveries? So after a lot of work, EMDR therapy, they decided together that they were going to go for another kiddo. So they went for broke, and they scored big. She won the lotto. She had a subsequent delivery, a beautiful little girl, Rose. But this is the picture on the right, which is Olivia, and what you can't see is how traumatized she is despite all of that work. She is in there, and her and Kim had talked deeply. All they wanted was Kim to be in the room that day. But what they talked about was, how do we cover the ceiling tiles? Because I don't want to see them again. And I also want to be able to see the faces of the team, because if the stuff goes down, she's going to have something to say about it. So she had a clear drape so she could see the faces of the providers, and she had a sheet over the ceiling. And I just share this moment with you because I think this is such a telling moment. Kim has been involved with our organization now. Their bond is forever. Kim goes to the birthday, we all go to the birthday parties. Like, she has truly earned the aunt status. And so oftentimes when we talk about anesthesia and your connection to the patient and how brief your time may be with that patient, I also recognize how profound these events and these moments are. We do a lot of caring for the carers. This is a series of pictures that somebody had taken that I wasn't aware of, but I gave a lecture, and afterwards there was a line of people, and I think all they wanted was a hug, which I'm here and I will give hugs. I mean, we can do a line here, we can do a conga line, we can do lots of things, but I'm willing to give hugs. So there was this woman in line, and now and so the point is that people just want to be heard and validated. Providers have stories too, and there's really not enough space for that. The bottom picture is a picture of a team in a very rural Upper Peninsula in Michigan. They had faced a loss. We supported this team right away. A long litigation later, and things finally were settled. There was no fault, but the team was so traumatized. And I found myself out at the NIH. At the time, it was in Detroit, and I was like, how far is this drive? I should go see, because I think you could get anywhere in a quick amount of time. Drove up, met with them, told them I was going to be in town. Their entire team showed up from that day, including their anesthesiologist. We sat in a boardroom for 2 hours, and I essentially asked them, let's talk about this. Tell me this is a safe space. And there were tears, I think, from just about every person. And afterwards, there was like an audible, like they had let their pants out after, Thanksgiving. You could tell that they needed that time to reprocess it even years later. So when I'm saying, and may I know that you had me come up to talk about how can we heal after these and how can we work together and collaboratively with patients, always centering the patient. And I thank you for this time, but I want to share, I'm not alone on this island. There are many organizations out there that have been founded by survivors or family members. The Accreta Foundation, the Preeclampsia Foundation, the Hyperemesis Foundation, Sepsis and Sepsis, the Rory Staunton Foundation, Sisters with Cardiomyopathy. There are so many amazing organizations. And so I just share, you can reach them through Mama's Voices, which is the coalition a few of us co-founded to help connect providers to patients. And then lastly, I just wanted to end. On the left is Dave and I. At the bottom is their son hugging my son. And both of our boys are learning how to drive, which is terrifying. I think he's been trying to take me out literally since day one, because I don't think my heart can take this. But all that to say is that I wanted to end with this, which is it has been a privilege to do this work for 17 years, and it's been a privilege to share these stories with you. I have countless stories, but I thank you all for your time.